I think for the moment, yes, we trust, but I think the nature of the exchange really requires an opt-in environment. So in San Diego, we extended invitations to almost 1,200 veterans who have care delivered both by Kaiser Permanente and the VA to potentially participate. These are basically shared patients across our organization. Next slide. And of that, we had about 40% return rate who have now been enrolled and are involved in all of this, and we are proceeding forward. Now, we are starting with you've heard earlier about the C32 continuity of care document, and that has a lot of data in it. We decided that we would start with a smaller set of data involving demographics, allergies, medications, problem lists, with the idea that we would expand out to other data elements as we sort of move forward and developed our sea legs. Now, I also do want to comment that the Department of Defense has implemented the NHIN infrastructure also and has exchanged data through the production systems with KP and the Veterans Administration in the San Diego environment. Their patient correlation activities are currently underway, and they will begin obviously doing this shortly. Next. Okay, so very briefly, our next steps. Regional expansion within Kaiser Permanente. We're just now in San Diego. We're obviously anticipating expanding within Kaiser Permanente. We recognize that's also an issue for the VA. There's also this issue of inclusion of additional partners, enrichment of data, as I described, functionality such as Doug was talking about in terms of new NHIN functionality. All of this has been pretty much, basically, we'll talk about that one. And then, of course, the business process improvements to authorization, correlation, which, of course, intended with any opt-in process. I should comment once again, and just let me put an exclamation on this one, that the technology in all of this is small. It's the agreements, it's the legal contracts, it's the willingness of the people to be involved. And I think that just it just dwarfs everything else. So if I leave you with one thought, just recognizing the importance of that as we move into the NHIN. Now, Steve, I'll turn it over to you for some additional comments.
Sure. Yeah, I was thinking as Simon was talking that it is some of these agreements, the standards, the policy decisions that are really the bow wave of all of this. And I was thinking about it watching the Olympics last night. This is a little bit like designing a bobsled while you're going down the run. So it's a fast-moving target. So we keep moving along as we're going. I'm not going to dwell on the VA, a very large national organization, which may explain in part why some of these initial interests in production exchanges are going on between entities that have similar use cases. Large footprint organizations that cut across state lines, cut across regional lines, and share the same needs. And if you look, it's very similar needs to what Kaiser Permanente has. I want to talk a little bit about why we chose this type of interoperability, why the NHIN. And certainly the VA has a lot of experience with electronic health records, 20 years of experience. It's been a major contributor to the development of the NHIN. The VA's electronic health records well known, and we also know that there's a lot more value in an electronic health record if it's interoperable than an electronic paper record. To really get the value of this, it needs to be interoperable. We know that within the VA system, we've seen the value of that within our own system in terms of quality and safety as well as efficiency. And we also know this with the DoD. Right now the VA and DoD currently share more data interoperability than any other two systems in the world. And this is just a busy slide showing the huge amount of data that's exchanged. But what's interesting about this is this exchange is really in a point-to-point way between the VA and DoD systems. And there's a variety of different feeds and ways that we exchange all this data. Obviously, this is not a terribly extensible solution. It certainly doesn't address our interoperability with the private sector. And one may ask, well, gee, if all veterans have originally come from the Department of Defense, why would we be so interested in the private exchange with the private sector? And part of this comes from the president's statement last year. And that was that we'll develop a virtual lifetime. I'm going to paraphrase this. I won't just read the quote. We'll develop a virtual lifetime electronic record that will contain all the health and administrative data for our military service members and veterans from the day they're sworn in until the day they're laid to rest. Now that's a big deal when one considers this. And I'm going to flip to this next slide. Over half of all veterans who receive care in our system also receive a portion of their care from the private sector. So that's huge. And in the DoD, when you look at the whole DoD system, it's over 70% of their care is delivered in the private sector. When you look at the families involved, when you look at service members, it's lower than that, but it's a significant part of care. So if we have a perfect point-to-point interoperability between the VA and DoD systems, magic wand, you've got the same system or perfect interoperability, we still don't deliver on the president's vision of having a virtual lifetime record because we're missing over half of all of the data that we need. Data exchange, we know, improves quality, safety, and efficiency, and you know all the reasons. I don't need to read those off to you. And right now, even though the private sector is more limited in their level of adoption through HHS's effort and others, we have utter confidence that this will increase. And not just from federal efforts, but frankly from the patients. In the end, I personally believe that the patients will drive increasing interoperability and health information ability within the private sector out of consumer demand. As patients start to see a value in this, they're going to kind of wonder, how come my doctor doesn't do this? Why isn't our hospital doing this? And I really believe consumer demand is going to be one of the legs that help drive this, in addition to incentives from the federal government, different policy enactments. I think consumers are a big part of this. And obviously what we want to do within VELR, within the VA, is to unburden the veteran from having to collect all of this health data. And when you think of a service member, so you've got somebody who received some of their health care before they entered the service in the private sector. Now they join the military, they go to Iraq, they get wounded, they come back to the VA, to the DoD, then they bounce to the VA, and then they go back to the private sector. Maybe they're reservists and they recover, and they go back into the military. Try to track all that down now when you're applying for your disability. Good luck. And so for us, this is fundamental in delivering not only health care, but also benefits. So VELR is not, obviously to this group, but something that we have to keep reiterating in many places is not a system. It's a strategy. It's a strategy that builds on our past experience to use standards, and we agreed on June 26th with the DoD to use the NHIN to accomplish that strategy for interoperability for the VA, DoD, and our interactions with the private sector, so that we can exchange data and have data for a veteran or service member whenever and wherever that service is delivered, whether within our systems federally or with the private sector. We think that'll be more efficient and effective than creating a single record between VA and DoD, because it gives us that outreach into the private sector. Also, it avoids a lot of the obsolescence of just building a single system. For us, the NHIN meets VA and DoD interoperability and provides other benefits nationally, in our opinion. Number one, national standards best fit our use case, much as it does for Kaiser. A statewide or regional or a series of different standards across the country really don't help us when we have a national footprint. Also, national standards we've put a lot of thought into, if we're going to pick the NHIN, does this make sense for the private sector? Not only in terms of providers, but for the vendors, the industry that provides electronic health records and different types of technology to us. First of all, we believe that standards will promote creativity in the marketplace because you know what to build to. You increase small businesses' opportunities because if you're developing a product, it's easier to productize if there's a standard to build to. It's hard if you're building fax machines and everybody's got a different fax, standard. It's really hard to productize something. You want to that'll increase consumer choices, and that'll decrease costs, which makes adoption even easier. And so it allows the authorized information exchange between systems that will maximize the benefits nationally. And so we're very committed to this, both for our system, and we believe this is going to improve healthcare nationwide. And the NHIN provides that standard that can empower the full potential of health information exchange. Right now, if we don't connect with the standard, this is what we have. The green. This is sort of our chiclet slide. The green is what we have right now, where we connect to each other, but we don't connect to all these other sources. What we'd like to go to this, where we're fully connected to their pre-military service, military service, their status as a veteran, wherever they're getting that care in the private sector or the federal sector. And just another cartoon of how this is going on right now. And this is something that's got an ongoing process, both a very formal, rigid process, because we are the federal government. And so people wonder who we are if we didn't have a formal, rigid process. And then we also have a less formal process I'll talk about. So phase 1A is what we're doing with Kaiser in San Diego, and that is that limited production pilot. The first time you try something, let's try it small. Let's find where the bugs are and address that, learn from that. And then as we get into 1B, where we'll pick additional sites around the country with different providers, based on the region that we pick. And those will roll out and will become full production online within this calendar year. So we're going to look at several other sites that will roll out this year. And that will be VA, DoD, and the private sector. Less formally is we're going to be looking as the VA at the ability to have interoperability with private sector partners wherever that opportunity lies. So, for instance, in large part, Kaiser was a target of opportunity for each other. We were both interested in this area. We were bumping into each other in San Diego, and that was a target of opportunity that the DoD has also been involved in. But we'll look for those targets of opportunity wherever they lie to promote this. And I just wanted to mention, because it's part of the President's vision, that eventually benefits data and health data can be merged through the NHIN and other systems that we have between VA and DoD to be incorporated into that virtual lifetime record. The fact that Social Security is already engaging some health information through the NHIN is a good example of how we can use that to improve our benefits delivery in the VA. So Veeler will maximize efficiency of resources and effort. Veeler can be part of community-wide health exchange. We want to be mindful of the HHS goals and help link what we're doing to promote those larger goals and ultimately improve health quality for the nation.
Well, Steve, thank you very much. A great presentation on the VA vision. Our next set of presentations are from Chuck Magruder and Brian Dixon. Brian, you're project manager with Regenstrief, and obviously thank you for joining us. And Chuck, you're on the phone also, I believe?
Yes, I'm here. Hopefully it's functioning. Yeah. Can you hear me?
We can hear you, Charlie.
Okay, thanks.
Yes, Charlie's going to start things off, and then I'll take it from there.
All right, if we could go ahead and move to slide number 2, please. As you can see from the diagram, we have the CDC down in Atlanta, and we have 3 state organizations, which I like to refer to as the Public Health/Health Information Exchange Collaboratives. If we start over on the right, you see the New York State Department of Health. This is a process that is managed by the New York State Department of Health in collaboration with the New York City Department of Health and Mental Hygiene, and also the organization of county health officials representing all of the other local health departments. And they work in collaboration with an organization called Health Research Incorporated, which is an arm of the state health department that coordinates their overall project. One of the unique aspects of this particular project is that it's a statewide process. That is, the state health department and the local health departments are working to develop a process throughout the state to interact with all of the health information exchanges. And they do have a well-established, robust plan for how health information exchanges will be developed throughout the state for that interaction.